My name's Kevin Bredo, and I'm the pharmacist owner at the Medicine Shoppe Pharmacy. So as a pharmacist, you get to see all sorts of different conditions as a community pharmacist, but mental health is something that I've really taken a bit of an interest in, and I feel that there's a real difference that pharmacists can make in mental health. So it's a very broad topic, what we're going to talk about today, and there's going to be things that we don't touch on, there's going to be things we don't get into a lot of depth in, but I'm hoping that everyone can kind of take home a couple of things that might make their job on the front lines a little bit better. And as I mentioned, as a pharmacist, you get to see all sorts of different things. I had a lady come in yesterday, and she was an elderly lady, and she was asking for birth control pills. And I said, well, Mrs. Jones, you're 65 years old. What do you need birth control pills for? And she said, well, they help me sleep at night. So I kind of scratched my head, and I went to my reference books, and I did some digging, and I went back to her and I said, I'm sorry, Mrs. Jones, but I just can't figure out how birth control pills will help you sleep at night. And she said, well, I crushed them up and I put them in my granddaughter's orange juice, and they help me sleep at night. So as I said, there's some fairly broad topics. We're gonna talk about kind of some main groups of medications: antidepressants, benzodiazepines. We're going to touch on cannabis, which is sort of becoming a hot topic nowadays, atypical antipsychotics, mood stabilizers. We're going to talk a little bit about herbal treatments, but there's not a lot of really good evidence about herbal treatments when treating, a lot of different indications, but particularly with mental illness, but we'll touch on it. Then we're going to talk a little bit about drugs of abuse. And then we're going to just touch on what services your pharmacist can provide. And I hope that there's one of the main take-home messages is that your pharmacist can be a fantastic resource for a lot of these cases. I'd love to be able to stand up here and tell you that when you have this medication and this medication or this medication and this street drug, this is what you should do. But the unfortunate answer is that it's not always cut and dry. It's not always black and white. There's a lot of gray area. The best thing you can do is communicate well with your client and your pharmacist to make sure that we get the best solution and kind of manage the risks the best that we can. So for each of the drugs, we're going to talk about the role in therapy, how they work, what precautions and side effects there are, some things to watch for. We're going to touch on duration of therapy, and then we're going to have sort of some pearls of wisdom, hopefully some kind of little insights that might just be helpful. So to jump right into antidepressants, as pharmacists, sometimes we get on the track of thinking that drugs are the answer to treat everything. But that's not always the case, as many of you know. Cognitive behavioral therapy is still the first-line treatment in depression as well as many other mental illnesses. So I try to make sure that I reinforce that. Drugs can be very helpful. They can help make CBT more effective, but it's very important to remember that as we go through this. Combining the two can often improve response as well. In general, antidepressants are sort of the same efficacy. So one may not be a whole lot better than another. And we often will choose an antidepressant based on the price, what insurance companies pay for, or side effect profiles. So we'll talk a little bit about the different side effects that different antidepressants have. And that's often what we use to make our decision. And I think when it comes down to, say, a family doctor or a general practitioner, they may get comfortable with 3 or 4 different antidepressants and choose those based on their comfort level. It's tough to know and be comfortable with prescribing all of them. So how can medications help? So they help relieve depression and anxiety in up to 70% of people who try them. They don't work well on their own. So again, back to the CBT, it shouldn't be your only coping strategy. It works best when used with CBT, support from family and friends, as well as exercise, good nutrition, and enough sleep. So just generally taking good care of ourselves is also an important thing. So this, I'm not sure how hard it is to see from back there, but this cartoon says, this antidepressant works best if you take it with water lapping near your hammock on a Caribbean beach. So So side effects. And these are going to be different for different classes of antidepressants and medications within those classes. But some people have none, others have many. And as a general rule, the side effects with antidepressants will lessen over time. So what I will usually tell people is that we're going to start with a low dose. And if people can sort of stick with it for the first week or two, generally we can work through a lot of the side effects. If it's too troublesome or the side effects aren't going away, then we may need to look at other options. But the biggest mistake that a lot of people will make is that they'll take 1 or 2 pills and they have some stomach upset or some diarrhea or this or that, and they say, this isn't working for me. The thing is that once they take those for a number of weeks, week or two, it often gets better. So if we can stick through those side effects, they're not too troublesome, we're going to get better results in the long term. The other thing to combine with that while we're on it is that we often don't see the benefits of antidepressants for 4 to 6 weeks. So what we're having is people get the side effects without any benefit and they bail. So it's important that people realize that. So the first phase, we decide whether the side effects are tolerable and manageable until our body adjusts. And then the second phase, at about 4 to 6 weeks, we'll often follow up with people to make sure that the medication's working or not. And if not, then we look at other options, of course. But side effects, different for each medication. Some common ones that tend to happen are dizziness, headaches, nausea, kind of trouble with memory, falls or drowsiness, and trouble sleeping. And depending on the type of medication, different side effects for each one. So the first class we're going to talk about is selective serotonin reuptake inhibitors. So this is one of the most common classes of antidepressants that we see used. It's usually considered first line for a lot of different things. And you'll probably recognize some of these names of medications as they've been around for many years now and they're commonly used. So SSRIs can be used not only for depression, they're also used for generalized anxiety disorder. With anxiety disorder, we tend to start low and work our way up, just because when we start these medications, they can often cause a little bit of anxiety. So to start low at a low dose and just gradually increases our chances of having a beneficial trial. Obsessive compulsive disorder, bulimia, social phobia, and post-traumatic stress disorder are all indications for the selective serotonin reuptake inhibitors. So how they work, it's a little bit, we're not entirely sure. So, which seems kind of funny considering how well they're used, but we have a theory that depression is in some way a deficiency in certain hormones in your body, one of them being serotonin. So one of the theories is that in these nerve synapses, so in between each nerve there's release of chemicals like serotonin or norepinephrine or dopamine, and they travel from one nerve to the next. So in people who are depressed, sometimes we feel that maybe there's a deficiency in this mechanism. And there's a diagram that touches on that, that I can help explain that a little bit further next. We also feel that sometimes we can change the structure of the DNA, which makes these transporters, which is a complicated mechanism. They may physically change the brain as well. So I'm not sure we entirely know exactly how all these work, but there are definitely some theories around hormones and serotonin. So on the right-hand side, we can see the little diagram, which is our nerve synapse, where on one side there's serotonin released, and it's supposed to hit a receptor on the other side. So the receptor is sort of like a button, and only certain chemicals will press this button. So the serotonin meets up with this button and sends a response through the rest of the nerve. So if there isn't as much serotonin in the synapse, that function doesn't work as well. So one of the ideas is that by blocking the reuptake of serotonin, we kind of flood the synapse with more of that chemical, thus changing the way that increasing the chance that we're going to get our desired response. It's a little bit complicated, but hopefully that gives us an idea. So the goal is to kind of increase the amount of serotonin that's in the area. So side effects with SSRIs, some common ones would be nausea, anxiety or drowsiness. Sometimes, on the other hand, there can be insomnia and diarrhea or constipation. So depending on the drug, depending on the person, we can get a variety of different side effects. Another one that can tend to be quite common with SSRIs is sexual dysfunction, which isn't one that people always want to talk about for obvious reasons, but it's something to be aware of because it can really impact someone's compliance with this type of medication. So the key for a lot of these medications is good communication and realizing that this type of thing can happen. And there are ways around it as long as we know kind of what's happening. Other ones like weight gain aren't always things that people are excited to hear because most people aren't looking to kind of add weight on. So this is something that sometimes is sort of a non-starter for people. So, and dependent on the choice of the SSRI is dependent on what the side effect profile looks like. So I also want to kind of take a note here and get off topic a little bit to talk about drug interactions. So these can be very complicated. Not all drug interactions are significant. So one of the frustrations I have at work is when people come in and they say, I Googled this and it says that I shouldn't take it with this. And in some cases that's fine, but it's not always accurate. And that's again why I can't stand here and tell you that you should never take this with this and you should never use this unless it's with this, because it can be a complex situation and every person is different. Some drug interactions are very significant. Some drug interactions are good. So if we say that you shouldn't be taking 2 sleeping pills together because it could make you too sleepy, sometimes that's what people need to do in order to get them to the right level of sleepiness, if that makes any sense. So we'll try to be very general today. I encourage people to talk to their pharmacist if they have specific questions about drug interactions because they can be significant, but they're not always, and it's an individual thing. So a little bit more on drug interactions. We see this guy's talking to his dad and he says, Dad, you might want to talk to your doctor about drug interactions. And it looks like there's a gang war about to start in his medicine cabinet. So some drug interactions are absorption related. We see this with multivitamins would be a common example, where a multivitamin will bind with the medicine in the stomach and neither are absorbed. So if the drug's not absorbed, then it's not going to do its intended benefit. Another one would be related to distribution in the body. So there's certain medications that are required to be bound to proteins, say, to transfer to different areas where they're going to be used. If that mechanism stopped or used up by another medicine, then that won't work as well as we intend. A big one that can get very complicated is metabolism. So there's enzymes in the body called Cytochrome P450 enzymes, which are responsible for breaking down a lot of these drugs. And there's a group of probably over 50 of them that's in our body. And it can be, to various levels, they can interact with the drugs that we're giving you to break them down and help them be eliminated. There's also some drugs that if you take them, they can increase the effectiveness of these enzymes or decrease the effectiveness of these enzymes. So you can see how that would get very complicated. If we give you a medicine that increases a certain cytochrome P450 enzyme, so it's working very active, another drug that we give you that's responsible for breaking down the enzyme is responsible, it could just eliminate it very quickly, if that makes sense. Also, to that same effect, if we stop that enzyme from working, other drugs may get to dangerous levels in the body because the way that it's broken down no longer is working. So that can get very complicated. Another one is excretion. This we often see in the kidneys. So medications that are eliminated by the kidneys, if we change the way your kidneys work, say with diuretics, something like that, can affect the levels of drugs in the body. And then there's enhancing effects, like we mentioned with sleeping pills before. If we give you 2 medications that can cause drowsiness, they can often amplify the effects of each other. So that's sort of some general discussions about drug interactions. And again, it's tough to get into too much detail just because it can be so individual. So again, this is about the cytochrome P450. They're a group of enzymes that break down medications. And drugs can increase or decrease the activity of these enzymes. And this can lead to complicated drug interactions depending on which enzymes they break down. So Back to SSRIs, we got off track a little bit, but things to watch for would be worsening anxiety. So particularly when someone first starts one of these medications, we want to make sure that the anxiety is not getting too troublesome or the condition is not getting worse. We want to look at drug interactions. One of the more serious ones that we look at with SSRIs is something called serotonin syndrome, if anyone's ever heard of that. Because we're increasing the amount of serotonin in the body, if we have multiple medications that are increasing the amount of serotonin, the serotonin levels can get too high. So this often prevents as sweating or increased heart rate, muscle twitches, dilated pupils, things along those lines. It's something that we definitely need to address. And it's something that I would recommend people go to the hospital and get taken care of if it was to present like that. We want to touch base with compliance. It's like I talked about, some of these side effects can start early without effectiveness. So it's important to communicate properly and make sure that people realize they need to stay on this for a period of time before it's going to be effective. We want to watch for side effects and effectiveness as well. So side effects will usually touch base with the first 1 to 2 weeks, and effectiveness at about 4 to 6 weeks to make sure that we're getting our desired results. This is kind of a little bit of a complicated flow chart here. So we'll try an antidepressant for around 4 to 6 weeks. If we don't get our desired response, depending if it's a non-response, partial response, or full response, if it's full response, we can stay on it for, this diagram says at least a year, just to make sure that we kind of get things back on track. Partial response, sometimes we'll make sure that we're using cognitive behavioral therapy. Sometimes we'll add other medications that will help enhance the desired effect. If there's no response at all, we'll often switch classes of medications and sort of start the process again. So some pearls of wisdom for the SSRIs. Citalopram, or its derivative escitalopram, so Cipralex or Celexa, have the fewest drug interactions in general. Fluoxetine or Prozac is one of the most anorexic, meaning it has a bit of an appetite suppressant effect, and it can also be a bit stimulating. The other nice thing about fluoxetine is it has a long half-life. So that means that it doesn't leave your system very quickly. And this is very nice when we decide to stop using something like Prozac, because that means that we don't get the ups and downs. It's going to gradually leave your system, and there's going to be a lot less withdrawal because your body sort of gradually eliminates it. Fluvoxamine tends to be the most nauseating, constipating, and sedating of the SSRIs. Paroxetine is one of the most anticholinergic. And by anticholinergic, I mean if you think of side effects like drying, so dry mouth, constipation, urinary retention, those types of things, can also cause some of the most weight gain, and it's harder to discontinue. And one of the reasons for this is because of the shorter half-life. So the levels tend to drop quicker, making your body feel the withdrawal when we're coming off of the paroxetine. So for that reason, it's one of the harder ones to come off of. Sertraline tends to cause the most diarrhea and tends to lead to the most male sexual dysfunction. So that may not be one that we would choose in, say, young males. The next class we'll talk about is serotonin and norepinephrine reuptake inhibitors. So examples of these would be venlafaxine, duloxetine. The one I didn't put on here is also called Pristiq, which is a newer class of medication. And this is just a diagram on the side. All those in favor of cyclophosphamide, I guess. I don't know. I don't know how they decide these names of drugs, but so role of therapy for the SNRIs would be depression and anxiety, similar to the SSRIs. An interesting thing with these ones is that they can also be used for chronic pain. Low back pain, osteoarthritis. This is something that we're starting to use more of as our society realizes that we maybe have too much of a dependence on opioids. And there's a lot of pressure to sort of resist the amount of opioids that are being used and find other alternatives to, because there's obvious problems with dependence and addiction with opioids. So we're starting to use some of these. The other issue with pain and depression, mental health, is they often go hand in hand. So if we have a medication that can work for both, that's a nice thing, because it means we can kind of kill two birds with one stone without adding too many medications. Patients with certain types of low blood pressure, because sometimes these can increase the blood pressure a little bit. It can also be used in fibromyalgia. So this is back to our diagram, and it's along the same lines as our serotonin, the theory anyway. But in addition to serotonin, it also blocks the reuptake of norepinephrine. So as well as the serotonin, there's also norepinephrine that we're going to flood those synapses with to hopefully increase the effectiveness of the chemicals in the nervous system. So some of the precautions, they may increase blood pressure. So if you've got someone with low blood pressure, that's fine. But somebody who may have high blood pressure to start, we have to watch that. Otherwise, they're kind of similar to SSRIs. There can be agitation or insomnia, nausea, tremor, or headache. And these ones can also have some significant withdrawal effects as well, like we talked about with paroxetine as the SSRI. So that's one that when we talk to people about stopping this medication, we like to encourage them to go slow. And we like to have them talk to their doctor or pharmacist as well to kind of set up a plan. But going slow will increase the chance that they're going to have sort of an easier time coming off of it. So things to look for would again be worsening of anxiety, drug interactions, and again, we talk about serotonin syndrome because this can increase the amount of serotonin. And the Cytochrome P450 system also can be impacted. So we can have increased or decreased effect depending on what other medications are involved. We want to always enforce compliance, talk about side effects and effectiveness, and make sure that people realize that in that first 1 to 2 weeks, there can be increased side effects without seeing the full effect for 4 to 6. So that's always something that I make sure that people realize so they know what they're expecting. So this may be a choice when we're looking for antidepressants with less weight gain, particularly at lower doses. They may be used in clients that have history of seizures because there may be less risk with that. And one that I like these days is commonly used with chronic pain. So these are some of the areas where we may choose to use this type of medication first off. So we're going to talk a little bit now about some of the medications that are slightly different than these class, but we still see used. This one, Remeron or mirtazapine, is an antidepressant. It's also used in anxiety. The really important thing about this one is it causes drowsiness. So we may use this as an add-on to an SSRI or an SNRI in clients that might be having maybe some stimulation that they don't want from their medication, and this may help them sleep at night. The other issue with this is that it can increase appetite and cause weight gain. So again, I've had people that I say, this medication may be a good fit for you, but weight gain is a non-starter for them. So that's something to consider. May help with sleep and agitation. And if side effects of agitation or with an SSRI or SNRI, this may help offset that. As a general rule, we don't like to add on drugs to treat side effects. If we can change the initial drug to make things just better from the start, that's ideal, but that's not always possible, so sometimes we have to add things on. Another one is called Wellbutrin or bupropion. And this can be used in depression or as an add-on in depression. The most common combination of antidepressants that we see are the combination of SSRIs with Wellbutrin or bupropion. And another advantage of this is it may combat the side effects of SSRIs. So there's less sexual dysfunction with bupropion. So that's an advantage. And there tends to be less fatigue. It can be more stimulating. So if someone's taking an SSRI that's working but causing them to have drowsiness, this might be an add-on. So decreased concern of that. The other thing about this is you may have heard of a medication called Zyban, which is used to help people smoking or quit smoking. And so this is used on its own for smoking cessation. And there may be less weight gain as a concern as well. So a little different than than just putting the patch over your mouth to quit smoking, because that would have other undesired effects, obviously. Trintellix is a newer antidepressant. Typically, it's just used for depression right now. There's a few exciting things about this because it has minimal concern of sexual dysfunction and less chance of weight gain. So if we're treating sort of young adults who those are issues for, then, or anyone in that for that matter, but this tends to be kind of that population, this might be an option for them. The one thing that tends to be limiting is nausea. This one's pretty predictable for that. The other thing is not all drug plans will have coverage. It's not currently covered under the Alberta Health Drug Benefit List, so that can be a restriction for people if they don't have private insurance or money's an issue. So the next larger class of medications we're going to talk about is called our benzodiazepines. So you'll probably recognize some of these names. It's a larger class of medications that's a little bit older. So I'm sure that Ativan and the Xanaxes, people kind of recognize those ones. This cartoon says, "Notice how much happier everyone is since I added anti-anxiety meds to the bottled water." So talking about anxiety, before I get into the drugs, I like to make sure that everybody's aware that non-drug measures are still very important with anxiety. So cognitive behavioral therapy. The thing with these benzodiazepines is that in a perfect world, we only like to use them for short-term treatment. So for acute anxiety or on a short-term basis, sometimes what we'll see is if someone's having a difficult time, we'll see a prescription for a benzodiazepine as well as an SSRI. And the idea would be to use the benzodiazepine for the first week or two until we start to see some benefit from the SSRI. We also see it for sleep disorders. It also has some muscle relaxant effects in some cases and some anticonvulsant effects. So there's a benzodiazepine called clobazam or Frisium, which is used almost exclusively as an anticonvulsant. So the way this works, this is sort of, I guess, just a zoomed in picture of a receptor or one of the buttons. And the benzodiazepine would interact with that receptor, and in doing so would initiate a chemical response in the cell. And the end effect is it sort of inhibits nerve transmission, reduces anxiety, causes drowsiness. So some of the precautions are drowsiness or dizziness or dependence, confusion, aggression or amnesia or memory loss. So the reason we don't like to use these long term, just for short term, is because they can increase the risk of falls or fracture in the elderly. So we don't even like to start them in the elderly if we can. Also an increased risk of vehicle accidents. And the risk of dependence is something that we try to stay away from as well. If we can get away from that, we'd sooner see someone take something like an SSRI, which can reduce the anxiety and prevent it, rather than kind of playing catch up with these benzodiazepines. So things to watch for: tolerance can occur to the sedative, the sleep, and the muscle relaxant effects, as well as the anticonvulsant, but there's less tolerance to the anxiolytics, so the reduction of anxiety. The thing, I say that we like to use them short term, but in practice, there's people who take benzodiazepines long term. And that's because the anti-anxiety effects still work for people. But because of side effects like risk of fall and confusion, and as we get to older adults, they tend to have less clearance, or the body doesn't metabolize these benzodiazepines as well. So we risk accumulation and the risk of falling. And then we worry about drug interactions, which increase drowsiness as well. So duration, we ideally use short term, reevaluate every 4 weeks. I like to think of it like a diaper. So you kind of have to look at it and make sure it doesn't need changing or different size, anything like that, every 4 weeks or so. So some pearls of wisdom. Withdrawal may be easier when we're coming off of a long-acting benzodiazepine. So something like diazepam, clonazepam or flurazepam are longer acting. So like the fluoxetine and the SSRIs, if they're longer acting, there's less withdrawal that you go through when you stop using them because your body sort of slowly eliminates it. And metabolism is impaired sometimes in the elderly. So if we start something like this in the elderly, we risk confusion and falls. So it's one of those things that we kind of like to avoid. So this is another sort of thought process. Again, we try to just stick to less than 4 days for the benzodiazepines, and if we get some relief, then that's great. We want to make sure we're doing cognitive behavioral therapy. If we need longer term therapy, SSRIs or SNRIs are better choices in general. So you can look through that kind of if you want to go a little bit slower later. So cannabis or marijuana is obviously something that gets talked about a lot, as it's going to be sort of legalized for recreational use July 1st. And there's a lot of talk about how it's going to be used, and it's being used for medical purposes for some time already in Canada. But in a lot of ways, it's still sort of like the Wild West, because we don't have a lot of really good studies for a lot of indications. So we'll talk a little bit about what we know, but we could probably do a whole presentation just on cannabis, medical cannabis. So these are some of the things that we often see is chronic pain, nausea and vomiting. That's one of the indications that has the most evidence today is for nausea and vomiting and chemotherapy, where other options hasn't worked. It can be used for people to treat anxiety. Some people use it to treat psychosis or convulsions or epilepsy. There's shown to be some anti-inflammatory effects for treating migraine, glaucoma, or spasticity in MS. And that's another indication where there's a little bit more evidence, is the spasticity in MS. So there's three major species of cannabis, and this is sort of an important slide because one of the important things that maybe people don't realize is that medical marijuana or cannabis isn't just one drug. There's 537 different chemical entities that exist in the marijuana species. The two main cannabinoids that we sort of focus on are THC, which is responsible for some of the euphoric effects. And then there's CBD, which is responsible for some of the anxiolytic, anti-epileptic, anti-inflammatory effects. And each species or each combination of marijuana or cannabis can have different levels of these chemicals and definitely different levels of the THC and CBD. So to say that one marijuana is the same as the next is absolutely, like, we can't say that. That's why it's still very much like the Wild West, I say, is because you can get one type of marijuana that may work for this, another one which does absolutely nothing, or may even make the condition worse. So the problem that we have as healthcare professionals is, first of all, making sure that if we're treating something, we're using a strain of cannabis that's been shown to be helpful in this condition, because one may help, others may not. The other thing is, you can imagine with all these different strains coming out, there's different producers coming out, is what proportions of these chemicals? And how can we possibly study all of these different strains without knowing more information and years of studies? So I really think that there will be indications and purposes for medical cannabis. The problem right now is knowing the safety and knowing the drug interactions and knowing which strain is going to work for each. So we really have to kind of proceed cautiously in all of this. This slide didn't turn out very well, but it again just sort of duplicates a few of the indications and what we're using it for. Some of the side effects, and again, like other classes of medications, it's going to be different depending on what levels of the chemicals of THC, CBD are in each strain. But there can be dizziness or drowsiness, dry mouth, impaired ability to operate machinery, which we're hearing about now. Long-term use may worsen psychosis, anxiety, or depression. They say that inhaling cannabis or using cannabis in less than 25 years of age can increase the chance of developing some of these conditions. It's also a class of medications that metabolize by this cytochrome P450 pathway. So as we know, this can be very complicated. And again, depending on what strain we use, may depend on which enzyme breaks it down. So we have to be very, very cautious with how we proceed. So things to watch for would be the consistency of the product. What I hope we don't see happening is someone ordering from their producer, getting a strain of marijuana or cannabis, and then finding it works and getting a different strain next time, because it's almost like getting an entirely different medication. We want to watch for worsening of conditions, and it can also cause worsening of bipolar disorder. So the little inscription on the cartoon says, "Can you prescribe marijuana to help relieve the boredom of sitting in your waiting room?" So some of the things with medical marijuana or cannabis is that they tend to be less addictive than opioids, which is interesting, because I think a lot of people have the perspective that it's maybe the other way around. And it does have a role, but I still think we need to do more information. So I really hope that pharmacists are involved in this process down the road. I don't know that we will be very involved at first, but I'm hoping that they include us, because I really think we have a role to play in analyzing drug interactions and how things interact in the bigger picture of people's medications. So here the cartoon says, we no longer have cigarettes, but we do sell medical marijuana. So maybe a little bit hypocritical on our part, but I do feel like there is a benefit for pharmacists in this. So atypical antipsychotics. And I chose to focus on the atypical antipsychotics as opposed to both the atypical and the typical, because I feel that we're seeing more of these atypical antipsychotics prescribed these days. So just without going into too much different areas, we're going to focus on this one. And these are the main ones that we're seeing in the Canadian market. Roll-in therapy would be for schizophrenia and other psychosis type disorders. It can be used to manage mania, and agitation in bipolar disorder. And it can be as an add-on in depression. It can also be used to cause sedation or help people with agitation in the evenings. So the roll-in therapy and the difference between this one and the typical one. So the typical antipsychotics would be more your older classes. These ones have a less risk of movement disorders. So by extrapyramidal side effects would be the pill rolling that you may see, mask-like face, or movement kind of shuffling disorders that the older classes of antipsychotics had caused. These atypicals may be more effective for the negative symptoms of schizophrenia. So flattening, lack of pleasure, lack of motivation. They may help improve those more than the older classes. They're similar in effectiveness with the positive symptoms. So by positive symptoms, we mean the delusions or hallucinations of schizophrenia. So how they work, it's again a complicated system of blocking certain dopamine and serotonin receptors. And there's various forms of dopamine and serotonin receptors, so it gets quite complicated. But it works more on serotonin and less dopamine compared to the traditional antipsychotics. So the little cartoon says, take the pills from the bottle without the cap to ease your arthritis enough to get the caps off your other medications. Sometimes that's the hardest part about taking the medicine, is just getting the lid off. So some of the precautions and side effects we watch for with these atypical antipsychotics would be the movement disorders or dyskinesias, because they can still occur with these atypicals, even though there's less chance. Metabolic effects. Some of them can lead to things like diabetes and increased cholesterol levels or weight gain. There can be heart rhythm irregularities. Some of them can cause increased prolactin levels. So that would lead to things like sexual dysfunction, gynecomastia, which would be breasts, I guess is the short way of putting it. And irregular periods would be caused by increased prolactin. So drug interactions, again, there can be QT prolongation, which by that I mean the heart irregularities conduction. So we can have really serious heart problems. And there can also be the cytochrome P450 enzyme related as well. So lots of things to think about with this class of medication. And the other complicating thing is that they all can be very different. So Abilify is one of the ones we're seeing quite a bit these days. One of the reasons is because there's less chance of weight gain than with a lot of them. So lower chance of changing the metabolic effects, lower prolactin levels, and lower sedation. So that's nice, less side effects in general. Safras is kind of along the same lines, although there can be a little bit more sedation. Clozaril is one that can be very effective, but it's not used very often. There can be higher metabolic effects. So out of the atypicals, it tends to be the highest weight gain. There can be high sedation. The other thing with this one is that it can decrease the levels of white blood cells. So if anyone's had any experience with Clozaril, we know that we have to go for blood work, monitoring weekly, regularly, and then we can increase to more if we're stable. But this can be very serious. So if you don't have white blood cells in your body, we increase the chance of infection. So we don't use Clozaril definitely first line. It's usually used in resistant cases because of that very serious potential. Latuda is another one, which we get a little bit more risk of higher prolactin levels and sedation. Zyprexa is a common one. A little bit higher metabolic effects, so increased risk of higher cholesterol and weight gain. And then there can be moderate with the other one, the prolactin levels and sedation. Invega is one that we see, but more commonly in its injectable form. So this would be an injection that's given every 4 weeks. And there'd be less metabolic and sedation, but higher risk of prolactin levels with this. Risperidol is one that we see very commonly. It has a moderate risk of metabolic effects, but higher risk of higher prolactin levels, less sedation. And Seroquel, again, is another one that we see, and it sort of fits into the middle of most of the categories as well. So things to watch for, side effects, of course, because they can be very extensive, and how effective they are. And with schizophrenia, as well as many mental illnesses, compliance is the issue. One thing we see is that people start taking them and they think that they're better. And in general, people have to take these sort of indefinitely. So it's something where we have to really reinforce compliance to keep people kind of on the straight and narrow with it. And we also watch for drug interactions as well as pharmacists. So some pearls of wisdom, just to touch on Clozaril as well. Again, it's the most effective, but the risk of agranulocytosis, or the decrease in white blood cells, sort of limits it, and it makes us monitor it a lot more carefully. There's also various dosage forms in this class, ranging anywhere from sublingual tablets to depot injections. So the nice thing about depot injections is we have to worry less about compliance in people. We give these clients an injection typically every 4 weeks, depending on the formulation, and then they just come in every 4 weeks. So we have to make sure they're getting their injection. We don't have to make sure they're taking their pill multiple times a day. It's a monthly injection, which really helps to improve compliance. All right, so mood stabilizers is the next one we're going to talk about. So there's kind of a bit of a range. Lithium is an older one that we've used for many years. And then we get into some sort of anticonvulsant type medications, divalproex or valproic acid, lamotrigine, carbamazepine, and then we're going to touch on the atypical antipsychotics because they're often used in the manic form of bipolar disorder. So the role in therapy would be often used in conjunction with non-drug measures, again, like we've talked about with everything. So exercise, sleep, avoiding substance abuse, caffeine, nicotine, and alcohol. And there can be very complex disease presentation. So I'm not the guy that would really be best at explaining all of the disease presentations. I'm sure that a psychiatrist would be a lot better at explaining that, but it can be very complicated to diagnose. So lithium has a very complicated mode of action, but at the end of the day, it sort of blocks a reaction in the nerves. So changing the way that the cycling occurs for bipolar disorder. Some of the side effects we see would be nausea, vomiting, or diarrhea. fatigue or fuzzy thinking. It can cause frequent thirst or urination, and weight gain or tremor. This medication is eliminated almost exclusively through the kidneys. So as far as drug interactions is concerned, we kind of have to pay close attention to any medication that can affect your kidneys, like diuretics, because, and making sure that people drink enough water to stay hydrated, because this can affect the elimination. Non-steroidal anti-inflammatories, so ibuprofen, naproxen can also affect lithium elimination too. So salt and caffeine can affect elimination as they work on the kidneys. There's many drug interactions, like I said, NSAIDs or diuretics. They're also going to be a very narrow therapeutic index. And what I mean by that is that the range between ineffective because the dose is too low and toxic isn't a huge range compared to a lot of drugs. So we'll often check the blood levels if we're concerned, because we can get a good idea about where things are by testing how much lithium's in the blood. And another thing we like to reinforce is compliance. Valproic acid, or divalproex, is originally a seizure medication, so to treat epilepsy, and it again affects nerve signal transduction in the brain. So by slowing down the nerve transduction, we reduce seizures, also helps reduce the cycling in bipolar disorder. This one can cause some nausea or diarrhea, can be weight gain, dizziness, or sedation. Divalproex is sort of a longer acting version of valproic acid. So it's one we often see because there can be less stomach issues than with valproic acid. We typically have to dose it fewer times a day as well. So we like to make sure that we take this one with food to help minimize stomach upset. We want to make sure we talk about compliance. And again, it's metabolized by the Cytochrome P450 enzyme system. And it can also affect the levels of the cytochrome or the effectiveness of the cytochrome P450 enzymes. So whenever you're combining any medications with divalproex, you want to make sure that the divalproex isn't going to interact with how these other medications work. Lamotrigine is another mood stabilizer. And again, it was originally used to treat seizures. Lamotrigine actually is a fairly inexpensive medication compared to some of the other ones. But most common side effect of this medication is loss of disposable income. So it can cause nausea, dizziness, headache, or drowsiness. One of the interesting things about this one is that rash can be very significant, and it's often the reason why we stop using it. So we tend to start very low and work our way up. And if clients do get a rash, it's important to get it addressed because it can be life-threatening in some cases. We also want to look at drug interactions. The nice thing about this one is that it's weight gain neutral. So generally, clients don't gain a lot of weight when they're taking lamotrigine. We want to look at compliance, side effects, and drug interactions as well. So these are sort of common themes throughout all of them. Carbamazepine, or Tegretol, is another mood stabilizer that has a complicated mode of action. And originally a seizure medication though. So we can sort of deduct that it works on the nerves to help kind of slow the transmission of the signals down. Some of the precautions and side effects would be nausea and vomiting. So again, it's good to take with some food. Drowsiness or dizziness. Rash can occur with this one as well, although it's not usually as big of an issue as lamotrigine. The controlled release version it tends to be better for side effects, and that makes sense because when we're using a short-acting product, the levels in the body are theorized to go up and down a lot more than if we use the controlled release, which sort of has a level, steady state in the body. So there's less highs and lows with the levels in your system. And there also tends to be minimal weight gain with this one as well, if that's an issue for people. There can be a lot of drug interactions. So carbamazepine is sort of famous for affecting these cytochrome P450 enzymes. So it may not be carbamazepine's affected, but carbamazepine can affect a lot of different other medications. So the pharmacist is asking this gentleman, how long have you had lightheadedness? The jokes are getting worse, as you can tell. So the duration of the mood stabilizer therapy is Minimum of a year, but lifelong treatment is usually recommended. So compliance is key here, because you'll have a lot of people that take the medication and feel like they're fine, feel like they're feeling better, but then stop taking it, which obviously isn't going to be beneficial if they have a relapse. So pearls of wisdom, we often use a combination of medications. So for bipolar people, and I apologize, I didn't get a lot into what bipolar is, but for people who sort of have the acute mania phase of bipolar, we'll often start with lithium or divalproex as a first line. It tends to work well. And for people who are on the more depressive side of the bipolar, we often start with lithium or lamotrigine, quetiapine, which, if you remember, is an atypical antipsychotic, and divalproex. And then in general, for maintenance therapy, we typically continue the medication that we started with if things worked well. But we may also need to add other medications to them. We don't usually use strictly antidepressants like, say, SSRIs in bipolar, because it can tend to trigger manic episodes. And that doesn't mean that we can't use antidepressants in bipolar. It's just that we don't typically use them alone. So herbal treatments, this is just to touch on for anxiety type conditions. Kava, which I don't know is even available in Canada anymore. There were some concerns with liver problems with it. And valerian are sold as treatments for anxiety. But there's not a lot of really good studies, is the problem with herbs. Doesn't mean that they don't work. It just means that there's often better options that have clinical studies done with them that we can recommend with sort of greater confidence, knowing what the effects will be. The problem with a lot of these is that no one stands to make a lot of money if they do a multi-million-dollar study on something like valerian, because it's available by many different companies. So that, unfortunately, is sort of what limits a lot of the studies that are done, and because of that, we don't have a lot of really good information. Some illicit drugs may trigger symptoms of anxiety, and we're definitely going to touch on that in a little bit as well. So herbal treatments for depression, there's maybe a little bit more evidence with some of these. St. John's wort is sort of like a natural selective serotonin reuptake inhibitor. It's an SSRI. The problem with that is that there's an awful lot of drug interactions with St. John's wort. So even though it's shown to be somewhat effective, I still don't recommend it because we don't know enough about the drug interactions. And I'd sooner see people use something that's been studied more. There's a couple other medications without a lot of really good evidence. SAMe, omega-3 fatty acids are a common supplement to use, but there's not a lot of really good information on them quite yet. Vitamin D is also something that people use, although again, not a lot of really good studies at this point. Illicit drugs may trigger symptoms of depression as well, but again, we're going to talk about that here coming up. People ask about pregnancy with a lot of these different medications. A lot of them aren't good in pregnancy, but I do encourage people to talk to their doctor before they stop taking anything or change anything, because it's sort of a benefit versus risk with a lot of these things. There's certain cases where we may choose to keep the mother on a medication that has some evidence that it causes birth defects, because the risk to the baby of the mother relapsing in her condition is greater than the risk of birth defects. So it's not always cut and dry. There's a lot of gray area, and it's definitely something where we want to weigh the benefits versus the risk of the medication, because we want to make sure the mother's health is in good shape as well. So we're going to talk a little bit about drugs of abuse. And like I've sort of mentioned before, I'd love to be able to stand here and tell you, yes, this is what you should do and this is what you shouldn't do. And if one of your clients is taking Celexa and they're going to go and you know they're going to use cocaine, then you should or you shouldn't do this. But unfortunately, everything's different. So the best thing to do, we're going to talk a little bit about them, but the best thing to do is to have them talk to their pharmacist, have an open discussion with their doctor, and just weigh the benefits versus the risks. Because some of these people are going to use these street drugs anyway. There's not much we can do. But to know kind of what the risks and try to encourage them to use safe practices is the best way of going about it in some cases. Alcohol is one of the most common ones. It acts as a CNS depressant, so it depresses the central nervous system. One of the concerns with alcohol is that combining it with Tylenol can lead to liver toxicity. So although it's probably fairly common for people to take Tylenol the morning after too much alcohol, it's not maybe the best practice. Metronidazole is an antibiotic which can interfere with the metabolism of the alcohol. So it can make you very, very sick. When people are taking Flagyl or metronidazole, it's very important not to drink any alcohol when they're on that one. Because it's a CNS depressant, alcohol may diminish the effects of antidepressants. So I get the question quite a bit about, can I drink while I'm on this medication? And typically there's not a real strong, it's not a real strong no-no. It's not something I encourage, but as long as people use the kind of moderation, it's usually not going to be a big deal. But again, every case is different. There can be some withdrawal, and if you've ever had a hangover, you may recognize symptoms of nausea or headache or anxiety, that type of thing. Another one is anabolic steroids, and they're obviously used to promote muscle growth. Some of the side effects can be reduced sperm count, deepening in voice, enlarged breasts, or facial hair in women. Can also cause high blood pressure. So this is something that we need to sort of be cautious with if someone's on blood pressure medication, as well as cholesterol. And can also cause changes in blood sugars in diabetics. So these are three major medical conditions that we see, sort of non-mental health related, that these anabolic steroids can kind of interfere with, particularly over the long term. They can also cause aggression, irritability, or delusions. So when someone who's already got mental health issues, these can sort of aggravate those conditions. Bath salts are sort of an amphetamine-like compound. And the cartoon says, "This is my first time taking bath salts." And the lamp says, "I think you're handling it well." And he says, "What the hell do you know, Steve?" So it's sort of a stimulant. Anything that stimulates the nervous and cardiovascular systems can lead to sort of some, you can sort of anticipate what it might lead to. We can get agitation, aggression, irritability, sometimes depression, particularly if you're coming off of these types of products. Because it stimulates the cardiovascular system, it can lead to high blood pressure, chest pain, and seizures in some cases, psychosis. It can lead to adverse events with antidepressants. So if it stimulates the nervous system, and I don't know we know exactly how this works specifically again, but if it stimulates the nervous system, we can sort of speculate that there may be higher levels of norepinephrine, serotonin, or dopamine, which could increase the chance of something like serotonin syndrome with antidepressants. So we don't really put a whole bunch of people on this medication, combine it with other things. A lot of the stuff we have is sort of anecdotal, but we sort of can speculate that when people use it with antidepressants or antipsychotics, that it may not lead to good outcomes. Cocaine is another powerful stimulant. We've seen cases of hypertensive crisis with antidepressants. So if people have hypertension or high blood pressure, we can sort of speculate that they might be at higher risk when combined with cocaine. Also can reduce the seizure threshold. So if someone's at high risk of seizures or using medications that may increase their chance of having a seizure, then this might be an issue. Increased heart rate, blood pressure, or alertness, which may lead to chest pain, seizures, stroke, nausea. It also may enhance increased heart rate with cannabis or other stimulants. Withdrawal can cause irritability or depression. So some people will choose to use cannabis with cocaine because there may be enhanced effect of the cocaine when used together, but obviously that's not something that is a good idea because we don't like the effects of the cocaine as far as healthcare professionals anyway. So, but it does happen like that. Ecstasy is another one that we see. The cartoon is ecstatic cling, but he's saying, "Woohoo, my pants are stuck to my socks, woohoo." It just reminded me of myself getting dressed in the morning, so I thought it was kind of cute. So ecstasy is both a stimulant and mildly calming. can cause confusion, depression, sleep problems, anxiety, paranoia, or irregular heartbeat. So we can sort of speculate that, again, if you have mental health conditions, that this isn't going to make things better in the long run. Serotonin syndrome is another risk. So this medication can increase the levels of serotonin. Reduced effectiveness of antipsychotics, again, can reduce the seizure threshold and may cause liver toxicity as well. Gravol is another medication that we see abused, and in some pharmacies we keep it behind the counter. It's traditionally used for nausea, but very high doses can give you a high. Alcohol, opioids, which are narcotics, and other CNS depressants can amplify this effect. So it's not something that, I mean, I don't think would be a very good high, but it's the type of thing that people are doing, so we need to be aware of it. Withdrawal can lead to excitability, loss of appetite, and stomach cramps. So Gravol, we know, can have a lot of drug interactions. It's quite a bit more documented. So if someone was abusing Gravol, we may have a better idea about what to predict if they're combining it with other medications that are prescribed to them. Heroin or fentanyl are opioids, and the biggest risk with those are CNS depression, as well as respiratory depression. And respiratory depression is when people's lungs basically just stop working. Our brain stops telling our lungs that they need to breathe. So this is sort of the risk with overdose of these medications. There can also be a lot of cytochrome P450 enzyme interactions. The main interactions, though, are from combining other CNS depressants. So other medications that kind of slow the way our brain works down, leading to respiratory depression. This cartoon says marijuana is still illegal, but opioids are half off for another 40 minutes. You can see that's happy hour from 4 to 6. LSD is a hallucinogen, so it may aggravate psychosis, agitation, and anxiety in clients who may even be predisposed to this. When people are on medications, tricyclic antidepressants, examples might be amitriptyline or nortriptyline, and lithium, those medications may increase the effect of LSD, while antidepressants, MAO inhibitors, which we really don't use much anymore because of the drug interactions, and SSRIs may decrease the effect of LSD. So those are sort of things that we have observed, and it acts on the serotonin system. So we can sort of speculate that if you're on another medication that uses serotonin, it can really play with things. Magic mushrooms are another hallucinogen. But it also works on the serotonin system. So again, we can kind of see that there's a lot of medications that can be in play with serotonin, can affect things. May lead to increased blood pressure or heart rate and anxiety. And it's a different kind of magic from what I understand than these mushrooms are doing. So methamphetamines is another, some of them can be prescribed. And what we watch for in the pharmacy in particular is hypertensive crisis. People who are at risk of high blood pressure, we want to watch with methamphetamines. Again, with the serotonin syndrome, can be a risk. They can have reduced effects of antipsychotics on people who take methamphetamines, and reduced seizure threshold. So people who have risk of seizures. Bupropion, if you remember, that's one of the medications that we talked about in the depression section. At high doses, they cause cocaine amphetamine-like effects. So again, a stimulant at very high doses. So increased blood pressure, heart rate, hallucinations, or seizures. And this, the caption on the bottom says, "When meds stop working." And it says, "Hey Pax, how you do?" Oh wow. Yeah, pink slip. Wow, that's not good. No good. Another medication is dextromethorphan, which is a very common cough suppressant that's in most cough syrups on the market. So at high doses, it can cause euphoria or elevated mood, disorientation, delusions, brain damage, seizures, panic attacks. So this is another one where it sort of sets off alarm bells when you're working in the pharmacy and you see people buying large quantities of dextromethorphan. It's often not for good purposes. Gabapentin is a medication that has a lot of different uses. It was originally used as an anticonvulsant. We now use it probably most commonly for chronic pain. As I touched on earlier with the opioid problems that we're having, we're starting to look more for other options like gabapentin to treat chronic pain. At higher doses may cause euphoria, relaxation, double vision, drowsiness, slurred speech. Can also have a fair amount of withdrawal, anxiety, insomnia, nausea, and sweating. So sometimes we need high doses to treat some of these people, and there can be beneficial effects. But when it's abused, it can cause problems. Another one that can be abused is levothyroxine, Synthroid, Eltroxin. This one doesn't really have psychoactive effects. It's more people use it to increase their metabolism. And at high doses can cause heart problems, confusion, or disorientation. So I guess what the goal would be by abusing it is by increasing their metabolism. They think that it's a way for weight loss. But the detrimental effects are obviously outweigh any chance of doing that, but it's something that people do.
Do you think somebody might use that as a stimulant?
Possibly. I haven't heard of it having stimulant effects, but it's possible. It's possible. That's a good question. Loperamide is a derivative of an opioid. So when it gets abused, we see it used, traditionally it's Imodium, used to treat diarrhea. When it's abused, it can lead to CNS depression, intestinal blockage, heart toxicity. So at high levels, it can have effects similar to other opioids. But again, the side effects like intestinal blockage, heart toxicity are not something we want to see. So just sort of winding down, I wanted to just touch on what your pharmacist can do. So making sure that you have a good relationship with your pharmacist is very important, whether it be on your client's behalf or as yourself. We have a lot of services that we're doing, and pharmacists don't just give out medications anymore. We're the most accessible health paraprofessional out there. We're doing a lot more medication reviews, so we're getting actively involved in people's complicated medications to see if we can change things for the better. So we'll sit down with people, talk to them about their medicines, see if there's anything that they're missing, anything that's not being used properly, or anything that maybe is unnecessary. And we look to kind of improve people's quality of life by doing a medication review. We also identify and solve drug-related problems, often arising from medication reviews. We can prescribe. Most pharmacists can adapt medication therapy. Maybe we've been in a situation where we're out of refills. The pharmacist gave us an extra refill because it was appropriate in long-term therapy. A lot of pharmacists, both the pharmacists at our store can do initial access prescribing. So that means we can initiate drug therapy or change doses depending on the situation. So sometimes it's something as simple as a vaccination. There's some pharmacists that are managing diabetes medication, pharmacists that are managing mental health. So it's a really exciting thing for pharmacists to do. A lot of pharmacists don't use it to their full capabilities because it's something where you really have to be comfortable doing it. But it is something that we're capable of doing. So it's an exciting time to be a pharmacist. We're also doing injections and immunizations. We do quite a good bulk of the influenza vaccines that occur in the province of Alberta now. We also do a lot of travel consultations, which lead to immunizations, pneumonia, Twinrix, those kind of things we can all do. We dispose of unused medications. We have a travel consultant pharmacist at our location that will sit down with you if you're going particularly someplace a little more exciting, maybe Asia or South America, talk about what the risks will be, what vaccinations or precautions you might need to take, and make some recommendations based on that. We also do weight management. And really the list of services that pharmacies are providing is even more extensive than this. So one of the most important things is to find a pharmacist that you're comfortable with, the one that you can ask questions to, and whether it be for yourself or someone, maybe one of your clients that you're helping with their mental health issues, because it's important that we act as drug information experts. That's what we're there for. So it's very important that you have that relationship, and that's what we're there to do. So don't feel bad about asking questions. So there's some of the resources that are available, which a lot of you are probably aware of already, and some of the references. So that's me. That's typically where I work. There's two medicine shops. That's the one that I'm normally found at. So if anyone ever has questions at all, please feel free to stop in or phone or email or whatever is your mode of communication.